Welcome to the review of Modules 6 and 7, which is all the cardiac information. Okay, the stars on the slide say that some information is on the slide or in the narrative of the slide that is related to a test question. Now, it could be the answer to the test question, or it could be one of the wrong answers to the test question are on those slides. So for each drug, look at the indications and the side effects. And then know the key clinical considerations that I have listed after each drug class and after each, like after heart failure or hypertension. These are the differences between the JNC 8 and the ACC AHA guidelines, and you do need to know the difference in their staging and when to initiate treatment, and what their goals are too for blood pressure reduction. There are multiple questions on this, where you'll be given a scenario and you have to determine which drug of your choices there is the one that you're going to begin treating with. So I can't emphasize this slide enough. Know it backwards and forwards. I highlighted some of the information. Some of this is repeated, like I know elsewhere it talks about NSAIDs contributing to high blood pressure. It also talks about NSAIDs contributing to heart failure. But you need to know the three core medications, then what the fourth medication would be, and potentially a fifth medication. There isn't a lot of information that you need to know about the alpha 1 blockers. These are typically not used like they used to be. You need to remember the first three from the previous slide. So this focuses mostly on the side effects of the alpha 1 blockers. Okay, ACEs or ARBs. Overall, we pretty much anymore use more ARBs, although you still see a lot of patients that have been on ACEs for years. So the advantage now is that the ARBs have come down in price. There's still, I think there's one on the $4 drug list, but otherwise than that, it's all ACE inhibitors on the $4 drug list. But they've come down in price considerably. But they rarely cause cough. The ARBs rarely cause cough or angioedema. They still can, but it's much less likely. So look at the indications for ACEs or ARBs. Here I have them listed. For hypertension or diabetic kidney disease, you can use either. For heart failure, it should be an ACE first, unless there's a contraindication. And one thing is, even if the person did experience angioedema, they can use an ARB if it wasn't a severe reaction, because again, the risk is less. Me personally, I don't think I would, but they say you can. Okay, ACE inhibitors, know its role in heart failure and post-MI, and what remodeling is and how it inhibits remodeling. Know what medications cause hyperkalemia besides ACEs and ARBs. What else? What other combinations would you not want to use? Know what medications you could give for hypertension and pregnancy. You can't give ACEs and ARBs, so what would you give? And then what are the indications for ACE inhibitors? Now for calcium channel blockers, you need to know the non-dihydropyridines versus the dihydropyridines. Now I have on the bottom here that the dihydropyridines may cause reflex tachycardia, and what that means is when the blood pressure goes down, the heart rate will go up. The indications. The non-dihydropyridines are targeted towards the heart. So we're going to look at things related to the heart, either angina or some type of dysrhythmia. And it's usually a supraventricular dysrhythmia of some sort. For the dihydropyridines, because it's not focused on the heart, it's mostly arterial. So we use it in hypertension and then in Raynaud's disease because it will decrease the arterial vasospasm in those fingers. But also look up, there's multiple drug interactions with calcium channel blockers. Look those up. Adverse effects of calcium channel blockers. With the non-dihydropyridines, remember it's focused on the heart and it's going to slow the heart rate down. So you need to be careful on the indications because we don't want it too slow. So has to be caution with bradycardia, sick sinus syndrome, heart failure, or second or third degree heart block because it can put them into complete heart block. Now moving on to the beta blockers. You need to know mostly the difference between the non-selective and the selective beta blockers. Also know the difference between metoprolol tartrate and metoprolol succinate. So metoprolol succinate's the long-acting one, and that one can be used in heart failure. But the metoprolol tartrate, the short-acting one, that can be given post-MI, whereas the long-acting one isn't supposed to. And I think that the reason for that is there's a better control of heart rate with metoprolol tartrate post-MI. Okay, these are the key considerations for beta blockers. I've highlighted the most important information, but again, you need to look over the key clinical considerations that I've strewn throughout your lectures. Diuretics. You need to know the indications for the types, including which ones can be given with a low estimated GFR. So you need to know especially loops, thiazides, potassium sparing, and aldosterone antagonists. Again, look at the key clinical considerations for each. Look at the contraindications for thiazides. And then again, as I talked about, the drug interactions that could cause low and high potassium as it relates to the diuretics and other drugs too, actually. Okay, I just wanted to point this out that we always think of the thiazide diuretics as being hydrochlorothiazide, but chlorthalidone has the most evidence for improved cardiovascular outcomes. And to be perfectly honest, I don't see this prescribed all that much, and I know the price is quite a bit more expensive than it is for hydrochlorothiazide, so I don't know if that's the difference or what. The metolazone is better for if the creatinine clearance is less than 30 milliliters per minute. The indications for loop diuretics are usually always fluid overload, so especially in chronic heart failure and pulmonary edema, not as much in just regular hypertension. I don't know what I put this one in here for, but they must have talked about other examples of loop diuretics in a question. So I think this is just to make sure that you knew which ones were loop diuretics. Hypertension, as I said, know both guidelines, the blood pressure, the treatment guidelines for the stages. Know what the best treatment for blacks or African Americans is. If no response to treatment, what to do? What are other considerations? The treatment of diabetes for possible renal protection. There's when there's known kidney disease, use an ACE inhibitor, but I see other sources that say differently. So an ACE inhibitor or an ARB for diabetes, and it's diabetes in particular with microalbuminuria and renal disease. And then look at the treatment combinations that can be used in hypertension. Remember never to prescribe both an ACE and an ARB. Okay, now we're moving on to hyperlipidemia. Okay, look at the risk factors for muscle symptoms. There are lots of different risk factors, so there's a question on that. Review drug interactions with the statins. It's from the CYP 450 chart, so you're going to have to look at the chart and look that over. Here are some of them. We have the azoles, fluconazole, any of those. Macrolides, except azithromycin, fenofibrate or gemfibrozil, grapefruit juice. What about heavy alcohol use? What would that do to it if you prescribed a statin or not? And then know which two statins had the least likelihood of drug and food interactions. These are the four groupings of benefits of statins. So you have to know these four backwards and forwards. I think there's probably 2 or 3 questions that give you a scenario, and then you have to pick which drug to give. So you need to know these 4 classes. These are the definitions of which are major ASCVD events and then which are high-risk conditions. Okay, these are the high, moderate, and low intensity statin therapy. This is one time where you need to know the percentages of each that you expect each to lower, and then you do need to know dosages on these. Now, we really only ever prescribe low intensity statins if somebody does not tolerate the moderate or high intensity statins. So I would focus on moderate intensity and high intensity. And again, you have to know the dosages. Okay, drug interactions for statins. There are multiple of them, and these are the 3 drugs that are the atorvastatin, lovastatin, and simvastatin are more likely to cause drug interactions. So you need to look at these because obviously there must be a question that asks about drug interactions. So it's this slide and the next one. And so just look those over. So how is statin therapy monitored? So you are to check the blood work at baseline, and then now you only repeat if the symptoms of hepatotoxicity occur. And so what are those symptoms? You need to look those up. You can do the ALT and the creatinine kinase if they're at increased risk for myopathy. And then if they do develop muscle symptoms or fatigue, then you can hold the statin and check this blood work, the creatinine urinalysis, to rule out rhabdomyolysis. And then check the fasting lipid panel 4 to 12 weeks after statin initiation. And then if you don't do a dose change, every 3 to 12 months. What do you do when muscle symptoms appear? You need to review this, but you need to see if there's any other causes, looking at interacting medications, take them off the statin for just a few weeks, and if the symptoms persist, it wasn't the statin. And then you can re-challenge at the same or a lower dose to confirm a link if they were improved. You can switch to a different low dose statin if needed, and then titrate up again. And if all else fails, you could alternate day or twice weekly if all other options failed. So know what to do. And here are the key clinical considerations for statins. Again, I wanted you to note that they're contraindicated in pregnancy, as are ACEs and ARBs. Now we're going on to the anticoagulants. This is heparin. You basically need to, I might have got these a little bit out of order here, but you need to be able to compare heparin and low weight molecular heparin. What's the advantages of one over the other? Here are the factors to consider when you're prescribing the DOACs. So I got it on the next slide actually, but you need to look at which ones have reversal agents, which ones are dosed daily versus once daily versus twice daily, which ones need an IV lead-in therapy, and what the indications for each are. So this basically says that. So the indications: DVT or VTE, AFib, mechanical heart valve, and pregnancy. Obviously, we can't use them in pregnancy or mechanical heart valve, so the mechanical heart valve would have to be on Coumadin. You also want to look at the goal in atrial fibrillation. Why are we giving these anticoagulants? What are we trying to prevent? Other things, the warfarin monitoring goals. What are we looking at? What the INR, desirable INR is. Aspirin indications for, I have, for prevention, basically, of CVD risk. AFib and DVT anticoagulant indications and goals. I already said comparison of heparin and low molecular weight heparin, and the benefits. And I kind of repeated myself there. ASA being used as CVD prevention. This was a new slide I had added, that there's always a concern with arrhythmias because it affects cardiac output. In the healthy heart, it affects it positively. So if I'm needing more oxygen, my heart, I may develop tachycardia, but it's beneficial for me. But in a diseased heart, it is not beneficial for them. It causes more oxygen demand on the heart, and that can increased ischemia with tachycardia. But anyway, all arrhythmias affect cardiac output in one way or another, and depending on the degree of decreased cardiac output, what those symptoms are. We talk about atrial fib and flutter, and we're mostly concerned with stagnation in the atrium, and also with the ventricular response to the atrial signals. If it's a rapid response, then the patients don't have enough ventricular filling time and their cardiac output will decrease. The antiarrhythmics, I think, are a very hard um, category because we don't actually prescribe them. We'll have patients on them, but it's usually the cardiologist that prescribes them. So you need to look at these for the indications and that all of these antiarrhythmics can cause other arrhythmias or it can worsen the arrhythmia they already have. So it is quite concerning in prescribing these drugs, and so that's typically why we don't. Amiodarone is prescribed often, and so look at some of these things that I have highlighted. You need to know how long is the QT prolongation and at what level, how many milliseconds do we care? If it's above X number of milliseconds, when do we care? You do need to know what to order for amiodarone monitoring. You may be needing to order this yourselves. Here is by the way, we're going over some of the class 3s because we use them most often. Again, this is indications, the Tickerson, and they have to be hospitalized for this to begin treatment. And they have the best evidence for cardioversion. Again, if you notice underneath there, it says avoid drugs that prolong the QT. Well, at what point is that QT? And I think when I discuss the narrative, I think it's on that slide. So, antiarrhythmics, know the indications and contraindications for amiodarone and dofetilide, which is the Tickerson, and the adverse effects too. Overall treatment with antiarrhythmics looks at the side effects, indication, etc. as a group. Why does the atrial rate need to be controlled in atrial fibrillation? Look again at the monitoring test for amiodarone. And again, know the prolonged QT length. Okay, now into heart failure. This is the last slide of this review. What is ventricular remodeling? What drugs may prevent or improve it? The ANRIs, the angiotensin receptor neprilysin inhibitors. You need to know the doses because there's the 2 doses and when to use them. Metoprolol succinate, not tartrate, carvedilol, and bisoprolol. They've all been shown to improve illness and death measures in heart failure with reduced ejection fraction. Know when to use ivabradine. I have to think about where the accent is on that. And when not to use it. And then when to use thiazides or loop diuretics in heart failure. And then there's a list of drugs that worsen heart failure. You need to know those also.